Hello, everyone, and welcome to How Storytelling Improves Health Outcomes, the Power of Your Story. We're so happy to have you in this session today. My name is Jamie Hilner, and I am the Director of Volunteer Programs and Advocacy at the Pulmonary Fibrosis Foundation. And I'm so glad that you chose to attend this session with us, and I hope it's going to be really beneficial for you because it's a really powerful presentation. Our speaker today is Dr. David Weil. Dr. Weil is the former director of the Center for Advanced Lung Disease and Lung Transplant at Stanford University Medical Center. He is now the principal of the Weil Consulting Group, which focuses on improving the delivery of pulmonary, ICU, and transplant care. Dr. Weil's writing has appeared in the Wall Street Journal, USA Today, Salon, Newsweek, the Chicago Tribune, Stat, the Washington Post, The Hill, LitHub, Tablet, the Times of Israel, Today.com, and the Los Angeles Times. He's also been interviewed on Fox, CNN, and the Doctors television show, and by the New York Times, the San Francisco Chronicle, and the Wall Street Journal. Dr. Weil's memoir, Exhale, Hope, Healing, and a Life in Transplant, was published in May of 2021. His novel, All That Really Matters, was published in June of 2024. With that, I'll turn it over to Dr. Weil.
Thank you for that kind introduction. Thank you for having me. I very much enjoy speaking to groups like this, and I appreciate the invitation. I'm going to talk a little bit about how storytelling, both mine and yours, improves health outcomes, and that the stories themselves are very powerful. You know, at its beginning, medicine started with humans helping other humans. It was very simple, right? But like all things human, the simple became complicated, and we all started to operate inside vertical worlds. She is the patient, I am the parent, I'm the doctor, they are the administrators. We got into very specific silos, if you will. It's a hierarchy and separation that's outdated, I think, and does not serve the needs of the patients and caregivers who need these worlds integrated much more than they currently are. It's a system, I think, that chips away at the heart of medicine and its very humanity, and that's going to be a lot of what I talk about today. Of course, there's no easy fix, and you guys all know this, for a $4 trillion industry that's fraught with many problems. But the shifting of medical care from physician-focused to patient-centered has proven to be an important priority as we work to improve patient experiences and health outcomes. And this shift is critical as we move toward more personalized care which looks out for the well-being of everyone involved with the system, whether or not they're a patient, a caregiver at home, or a clinical provider, people like me. Today, I'm going to offer a model of collaboration as we consider all three perspectives, that of the parent, the patient, and the provider, to illustrate how narrative storytelling and story hearing can help all of us work toward a more equitable, effective, and personalized level of healthcare. Let me give you some examples. To make peace with her prognosis, I had a patient who started writing in her journal at the age of 15 and didn't stop until her death at age 25. And some of these writings eventually became her book. A parent began a memoir, much of it a meditation on universal truths about loving and losing and looking for answers to the big life questions. And writing these real issues became the only kind of writing that mattered. When she realized that sharing her story could help others and that serves a larger purpose, she had accomplished something that was much more significant than one book or one story. In my 25 years on the front lines of medicine, first with AIDS patients and then as a lung transplant doctor, as was said in the introduction, I was witness to what's great in a hospital: inspirational patients, brilliant colleagues, devoted caregivers, miracles that happen when lives were saved. But I was also, unfortunately, part of a system that included medical errors, ego-based clashes between doctors, and profit-driven decisions that were made by hospital administrators. So I came home from the hospital every night with stories in my head, stories that needed to be told, and writing my memoir and my recent novel allowed me to share the emotions and the questions that arise when I was caring for the sickest of the very sick. There's demonstrable science behind what we all know to be true. We learn facts about a person's situation, about a patient's situation. And sometimes it can be hard to empathize if the only thing we focus on are the medical facts. But if we learn their story, we begin to really care. We're invested. There's a neuroscientist that I've read quite a bit from named Paul Zak, and he was the first to discover that our brain synthesizes a chemical called oxytocin when stories engage us, and that the molecule also motivates reciprocation. When we're empathetic to a person, they're empathetic back toward us. And as we speak, we encourage you to remember that medical records exist for these stories, and that these records that only reveal data are not doing our patients full justice. This is me as a young medical director of a new transplant program. Way back, you can tell by how young I look. This is Brian. He was one of my first patients right after I got out of training. He was 19 at the time, shy, and had a developmental disorder. I spent time with him trying to get to know him and his situation. And I want the team, the whole transplant team, to put him on the transplant waiting list, but I have no idea how the selection meeting will go. I presented the details of his case, shading the presentation, a practice I learned early on to persuade colleagues to get him on the waiting list. I highlighted his sweetness, his family support, and downplayed his learning difficulties. I said, yeah, he's got learning challenges, but he's got a very committed family, and he was compliant with his medical regimen. And I was met with silence from the team. Eventually, after some tense back and forth and logistical conversations that come up when we talk about potential transplant recipients, the transplant team gave the go-ahead and we listed him. But Brian, like everyone, then is more than data in his medical record. He's much more than that. So as a clinician, we must develop an understanding of what our patients need and want, and then try to give it to them. We have to connect with them emotionally and with empathy. But we know that patients and their families have different backgrounds, socioeconomic statuses, and they have their own unique hospital experiences. And we need to be flexible in how we engage with them. We also know this too. Too many medical errors that happen in the hospital are caused by poor communication. Medical errors that result in up to 250,000 deaths per year in the United States. So we must deliver hard truths to patients sometimes. We have to tell them things that they don't want to hear, but we always have to offer hope as well. A patient's right to know everything should supersede a doctor's reluctance to reveal everything that we know. But it's hard for providers to deliver difficult news. I did a lot of it during my career. It never got any easier. But it's even harder for patients and their families to receive it. And I knew that. People with chronic illnesses and those who care for them navigate the space between living and dying all the time. That's what they live with. So when Brian, the patient I was telling you about, first came in to see me about a transplant, I noticed the way his mother held him close. It was obvious she was familiar with guiding him through very stressful situations. And I could tell she loved and understood her son in the way that only someone who had stayed up all night, night after night with a sick child could. I had seen this many times in my career. Young patients who had been sick all their life, and their illness truly became a family disease. But what happens on the caregiver side of things? Doctors, and I'm being frank here, don't always want to hear from people who actively engage, who push back or ask questions. These kinds of people, regrettably, are deemed difficult, thought of even as an impediment to our ability to deliver care. But so often the caregivers are the primary day-to-day support system that bring crucial perspectives on a patient's emotional and physical state. They're invaluable. Caregivers in this country are almost always an unpaid family member, and there are 53 million in this country as we sit here today. 53 million. Caregiver syndrome, stress syndrome, is real. It's an emotional and often physical exhaustion compounded by the distress of loving their person too much. Stories underscore the need to put humanity back into healthcare. Our system, which is not a system at all, but rather a fragmented set of profit centers, is in danger of losing its soul. Some people would argue that it already has. And instead, replaced by an unruly behemoth that is neither efficient, equitable, or manageable. And this uncomfortable truth is due to many factors, many of which you're very familiar with. Insurance companies dictating patient care, overscheduled patient encounters in the clinic, consistent placement of profit over purpose. Patients need their doctors to treat them and provide therapies, of course, but doctors need to spend as much time hearing patient stories as they spend tending to the medical record, something that needs to be fed every single day, every hour of the day in our hospitals. So developing the ability to engage or to draw out a patient is a clinician's most valuable tool, and one that can be difficult to learn. As a matter of fact, I trained a lot of people over the course of my career. It was the hardest thing that I had to teach them. The mechanics of medicine were fairly easily learned, but this one was hard. And historically, the medical interview was the pillar of medicine. Nowadays, and you all know this, a patient is asked a perfunctory, "What brings you here today?" with no eye contact or responses simply typed into the computer without ever laying a hand on a patient. So we can start and acknowledge our patients' humanity by making sure to ask questions not only about their medical self, but also their personal self. It's easy to do. I would ask a question: is there anything that you can't do now that you would do if you could breathe better? A simple question. I began to ask it early on in my career, and I asked it during every one of my lung transplant consultations. And the patient's responses that I heard thousands of times over the years could be as simple as, "I want to hang out with my friends. I want to chase my grandkids. I want to be a better partner to my spouse." Their answers helped me understand what they valued and wanted. And it was a great way for me to get them to talk, to reflect on their motivations, their dreams, and start to envision a new life for themselves. Let me tell you a little bit about my own story. So failure was never on my agenda, nor were mistakes. My plan was to save lives and not lose them. Through the years, there were lots of deaths in the kind of work that I did. Each one was traumatic to me. And we physicians have an innate desire to control circumstances. It took a long time for me to acknowledge that many circumstances are simply not controllable. At the height of my career, I suffered a crisis that upended my life, my career. Some would call it burnout, but burnout suggests that the problem resides only within the individual who lacks the resilience to withstand the work environment. I would argue that burnout is much more than that. It's a type of moral injury resulting from an array of factors: the corporatization of medicine, the drudgery of the electronic medical record that I mentioned earlier, hospital politics that don't make any sense and don't help patients, the dehumanizing way physicians have traditionally been trained. I worked around 100 hours a week during my training period, and not very good for the soul. These factors then lead to a higher risk of medical errors and double the risk of adverse safety incidents, which leads to lower quality care, decreased patient satisfaction, and even worse outcomes. We all, and you've heard all the terms about fighting the disease and losing the battle. These are cliches, yet we still use them all the time in our hospitals. Are patients to feel like they've failed? Words have power. Patients don't fail when they die, and providers don't fail when they can't ultimately prevent death. Let me tell you about a study out of Northwestern's Feinberg School of Medicine. They use professional actors and simulation-based mastery learning course practices to train physicians to deliver bad news in a clear and compassionate way. The study found that every medical student who received the interactive training acquired the skills necessary to have these hard conversations. It can be taught. A clinician can improve at this very important skill. And these conversations should involve introducing palliative care, for instance, but most physicians view palliative care as giving up, as throwing in the towel, as failure. And this is wrong, but it doesn't mean that this is not the prevailing attitude of too many of us who take care of patients who are always at risk of dying, who have serious diseases. All the more reason that patients need this kind of support. Patients constantly walk a tightrope, navigating between being sick and being well, just as clinicians navigate between emotional connection to our patients and keeping a professional distance so that we ourselves don't get hurt by these interactions. Treating patients, real people, like data points not only hurts them emotionally, it's an impediment to good care. But when every daughter became my daughter, every wife my wife, every mother my mother, was that a good or a bad thing? I could argue both ways. So there are never any guarantees of life for anyone. Having thoughtful and transparent conversations early on with patients when you first meet them and their families can create a common set of expectations and a common understanding of what exactly I can provide as a clinician and you should expect as a patient or caregiver. As I mentioned, there are many systemic problems in healthcare. You've probably heard about all of them. But sometimes looking at a particular patient, a particular case, as we say in the hospital, can shine the light on a larger issue. And I'll give you an example of this. So early in my transplant career, I approached a woman whose son had been declared brain dead. So they were a potential organ donor because of that. The family pastor, who'd known Donald since he was a little boy, quizzed me, trying to ascertain whether everything had indeed been done to save the young man. He wanted to know that so that he could then go back and tell the family that. The grieving mother didn't believe that there was no hope, and she was vehement. She would not consent to organ donation, even though her son was clinically brain dead. At first, I was so invested in saving my own dying patients, those patients on my waiting list that I carried in my pocket every day, that I honestly couldn't understand why she felt this way. But then it occurred to me days later that she may have suspected that we could have saved her son, but chose not to. And that really got me thinking. She was a Black woman and I was a white doctor in a white coat, telling her that her son was dead when her whole family could see that his heart was still beating. It was hard for her to understand that. She didn't trust me, though. She didn't trust the white medical establishment to do the right thing. And that's one of the obstacles that we need to overcome in our healthcare, the lack of trust. But her skepticism was well-founded. It was part of a collective distrust that long predates the much discussed Tuskegee syphilis study in 1932, where there was historic and ongoing mistreatment of people of color. And in order to correct the imbalances of implicit and explicit racial biases in all areas of medicine, we need to expose these injustices and right these wrongs. We need to do it through storytelling. We've got to continue to tell these stories. So data can tell us something that's true, something we know, that people of color are less likely to donate their organs. It's a fact. It's been a fact for the 30 years I've been involved in transplant. So data tells us that. But I would argue that stories tell you why that is. And that's one story that I think told me why that is. Since narrative styles differ so much among patients from divergent cultural backgrounds, I think it's necessary to bear witnesses to voices from all communities, and we've got to improve at that. Understanding the nuance and complexities of people's stories allow us to move past our own biases, and we all have them. Whether we're aware of them or not, we all have them. And we have to look more broadly at definitions of health beyond what's just in our medical school textbooks. Because at heart, we're all human, we're all connected to one another. Pain, suffering, disease, grief, none of that has any boundaries. Not according to socioeconomic status or race or gender or anything else. So I would argue that storytelling can play an important role in the curriculum for medical training. During the medical interview, when we're talking to patients about why they came to see us in the first place, in clinical practice, with peer-reviewed evidence, and with health education campaigns. And this last point I think is important. Stories can prompt scientific inquiry, get people to ask, what if? What if? We know that stories aren't going to cure the toughest problems that we face in healthcare. But we do know that stories can provide that what if spark in scientists and get patients to ask, could it be? We want all potential treatments vetted using rigorous scientific methods. I think we've seen recently during the COVID pandemic what can happen when we don't do this. But all discoveries in medicine begin with an idea. They begin with a story. And I think that that's the power of it. So as was mentioned in the introduction, the kind introduction, I wrote a book called Exhale, Hope, Healing, and a Life in Transplant, to share the human stories of my patients and to pull back the curtain. And this was the most important reason why I wrote it, to reveal what a team of people can go through when their decisions determine who gets a second chance at life. I wanted to bring that to the forefront. But the most important part, the best part of writing the book was when I went on book tour afterward a few years ago, and I got to engage with healthcare workers and patients and caregivers in a way that I never had before. I see now and understand the challenges that they and we face better than I ever have. And I went back to the page to write about it some more and published a novel in June that went even deeper than my memoir. Sometimes they say that fiction is a pack of lies that tells the truth. And I thought I was able to get into some of these issues even more with my own novel. But the one thing I learned, probably the most important thing I learned, is our profession perpetuates the myth that doctors are superhuman. We're not. And that may be obvious to all of you, but sometimes we look in the mirror and we see something different. those of us who chose a career in medicine do so because we want to heal people. That's how we start. And when we aren't able to, it impacts us. The effects can be devastating. They're personal and real, and they're soul crushing. When I experienced my own career crisis, I turned to writing as a form of healing. And it was a way of connecting with people who understand and those who need to understand the perils of our profession. And that's been the most important part of all of it. So, to anyone involved with our healthcare system, whether it be patient, a provider, or a caregiver, I urge you to consider writing your own stories, the trials, the successes, the failures, the lessons learned from patients and family members and caregivers, and then share them with your friends and family. And if you want to, with the public as well. They're important. It's important for us to all share these stories. Because I think when we tell stories about real people who interact with the healthcare system and suffer indignities, when we reveal disparities, or when medical errors that harm real people come alive on the page, we're putting human faces on events and statistics that only stories can explain. Stories that trigger oxytocin in our brains and remind us why we entered this profession, if you're me, and what you can do better as a patient and caregiver if you're you. Patient stories, medical memoirs, basically any human tales of resilience, loss, bravery, grief, revelation, triumph, they can lift us up and generate the empathy that motivates each of us to help each other, to keep going and to survive. Medicine and literature have long interacted with one another, long ago intersected. But to really improve outcomes, we need patients and their caregivers to share more. We need to hear more from you. There's been a lot of doctors, nurses, other caregivers who have written books and essays and newspaper articles. We need to hear more from patients and caregivers to reveal clues, the way that empathy motivates each of you to help each other to keep going and to survive. We need also to continue, though, in addition to family members and patients, to hear from caregivers who are, in my opinion, and based on my experience talking with these kind of folks every day, under assault from an unhealthy hospital environment right now. So I'll wrap up soon, but whether you're a patient, a caregiver, or a doctor, none of us have all the answers, not one of us. But all of us have important voices, and voices that add to the collective consciousness about the power of storytelling. And these voices all come back to one place. They remind us that humanity is the soul of medicine and always has been, and I think always will. I really appreciate the opportunity to talk to all of you, and I'm happy to answer any of your questions or just hear your thoughts.
Thank you, Dr. Weil. That was an amazing presentation, and I think really resonates with our community on the importance of the stories and hearing not only from the patients, but also their caregivers and connecting there. As mentioned, if you have any questions for Dr. Weil, please submit them in our Q&A at the bottom of the screen, and we can help answer them there. But I do have a few questions to start us off. So Dr. Weil, when the power of your story, but how do you take kind of some steps back and think when you're first starting out, maybe when you were starting writing your novels or books, how did you start framing your story? There's so many components, there's so many pieces, and how do you kind of find your focus on what you want
Yeah,
to share and the message to get across?
Yeah, thanks a lot. All the two books that I've written started as scribblings in a journal that I kept while I was treating patients. And the journals sometimes the entries were in bullet points, they weren't even in sentences. And I walked around the hospital a lot of the time by myself, often late at night. And I almost felt like turning to an imaginary person and say something like, "Are you getting all of this?" Because it really was something that I was experiencing, and I was often experiencing it alone. I want I wanted in my own writing to draw people in to what does it feel like to do the kind of job I did, but also what does it feel like to be a patient in the bed? And a lot of the stories that I write about from a patient's perspective are about the successes and the fears and the anxiety that go along with having a serious illness. And I wanted people that were neither care providers or patients to really understand and feel what that environment is like. And that was the main goal when I sat down to write.
Thank you. Um, Kind of now taking on to the next step of the process of writing your story and having that, but I think sometimes it's easier for some individuals to share it more like externally, whether with like their healthcare provider or more publicly than with their tight-knit community to or like their caregivers or things, because it can be a little bit more difficult to show them kind of what's all going on. If you're kind of having difficulty navigating sharing that story with your most inner network, how would you recommend kind of navigating those challenges and being able to share with those that you love?
Yeah, I struggle with that too, because I was the kind of person that, even though married to a nurse, I would not come home at night and talk about the hospital. We would talk about other things, our kids, what was going on with them, and just the day-to-day stuff. I think that for me, it really required me to write it to really understand it. And so I had to write it all before I could tell the world about it. And I think what's interesting is there were some people that that have known me pretty well that had no idea any of that stuff was going on in the hospital because I didn't share it. And that's not good. I think it's probably more helpful to share some of these experiences in real time. As much as I think writing is great and I think it's important, I think it's probably even more important to share the experiences in real time. And I did not do a great job of that.
Thank you for that. We got a few more questions coming through. Um, just how impactful your and insightful that your presentation was, and how can this message being shared more with other physicians and knowing doctors and physicians that they see personally, how can you kind of share this message with them, or how can patients act on that and share with their physicians?
Yeah, those are all. I'm trying to share as much as I can about the approach that I think is the best one, not only for patients but also for us as providers. So, not only in my writing, but I go around and talk with a lot of groups, and I have a consulting practice that works on some of these issues. I think in terms of being a patient, and I've had family members that uh, have been patients. In fact, my father, to whom I was very close, received a liver transplant very early on in my career. So I got to see it from that side. I think one real goal that patients should have is to make sure that the doctor understands that you're a human being. Tell them a little bit about yourself. Tell them things that are personal. Tell them things that you like to do. I used to ask patient questions about, what would you do if today was your last day? And any answer was a good answer, but it allowed me to get to know a patient personally. If your doctor doesn't do that, tell them anyway. Tell them what's important to you. Tell them why you want to keep on living. Tell them why you want to breathe better. Tell them why you want to transplant. What are you going to do with it? Because I think one thing that may not be very well understood, because we've done a good job of hiding it, that doctors are human beings too. And I think if they start to care about you as a human being and not a set of data points, you'll get better care. I wish that wasn't true, but I think it is true. I think that doctors as human beings, nurses as human beings, pay a lot of attention to the people they know better. I think that's really important.
No, that totally understand. And I think that's something that everyone is trying to, that's why this session's so important, is trying to share that. It kind of ties into a submission that we just got with a question of when someone's pulmonologist or their physician they're seeing with has been told that they ask too many questions. And they're trying to make sure that having their physician understand I do have a lot of questions, but I'm not trying to be difficult. I'm trying to be more critical or understanding of this, and knowing that they have only a certain amount of time they could spend with them or do things. How can you kind of approach that conversation of maybe changing the view of, not maybe it's not too many questions, but I just am looking for some clarity or help?
Yeah. Yeah, unfortunately, and I don't have to tell this group this, but unfortunately, a result of our healthcare system is doctors and patients don't get enough time to do anything. What I would say to your doctor is, and this is a great question because I think it's really important, is I have a lot of questions. We probably don't have enough time to answer all of them today. What is the best way for me to get the answers to my questions? And that could involve, and I did a good deal of this when I was practicing, that can involve setting up another time to talk outside of the clinic setting. I did a lot of that. It could involve an office visit that is scheduled for a longer period of time. It's just going to be question and answers, a separate one from the traditional clinical evaluation, 15 or 20 minutes out the door. I think it's important for patients to communicate to their physicians that they need more from them, but let the physicians come up with a way that that can happen. I'd be very surprised if a doctor told a patient, this is your only shot at it. Take it or leave it. I'm not going to provide any other way to answer the questions. I'd be surprised at that. I'm not saying it's impossible, but I'd be surprised at that. I think give them the opportunity to answer your questions outside of a period where they're in a hurry. And those opportunities exist. I think they do.
I think that's a great kind of, I think sometimes having to address it maybe in a separate meeting, or thinking this is my one shot, and it's just maybe setting up a separate time to go through that more, or someone else in the office, is a great idea.
Yeah.
We did get a question. So when kind of nearing the end of kind of your journey with pulmonary fibrosis and the options that there are out there for treatment, or if you don't qualify for a transplant, but you're not ready to kind of move more towards palliative care, hospice, what should someone do? What are are there other options, or where can you look to go?
Clinical trials, I think clinical trials networks, I know the PFF is very involved in that. And I think getting to a physician, a pulmonary fibrosis physician that's involved in clinical trials is a good in between traditional medical care for pulmonary fibrosis and transplant. I think it's an in between. Some of those drugs and some of those trials obviously are investigative, they're at early stage, but I think it's a good in between the traditional medical care and transplantation.
Thank you. And we're getting a lot of in our Q&A saying that loving your book and have read it. So getting a lot of
Thank you.
support there. One of the questions we have is talking about storytelling, but talking about writing, kind of storytelling through writing songs and doing home recordings and getting that as another sense of release and emotion. Is there other kind of practices that people can do, or maybe kind of storytelling outside of just traditionally writing it out?
Yeah, I think writing it out is for some people and not for others. I think, writing is difficult. And not only is it difficult, it may not be the best way for everyone to communicate. I think a great way to get these stories out and probably the most efficient way is to talk it out. In other words, talk with your family and friends about what you're experiencing and what disease you have. I know there's support groups. I spoke to the ones at Stanford when I was there all the time. I think those are great ways to quickly get out what you need to say. I think writing appeals to certain people that are in their own head a little bit, and I would categorize myself as that, and also have the patience for it and can do it over a long period of time. But I think if you're more interested in just getting your story out, find a group of people that you can talk to about it. And support groups are a great way to do it. And I'm sure many of you are in them already. But also just sitting around and talking with your family and friends about it. I mean, I think my experience has been that sometimes family and friends don't initiate the conversation because they don't know how to with somebody that's sick. Do it for them, make it easy on them, and tell them what you're experiencing. And I think you'll find a receptive audience.
And on kind of the opposite side of that is seeing our patients, seeing their caregivers, and you talk about the caregiver a lot in your presentation, wanting to make sure that they're taking care of themselves, that they are reflecting on this, that they're doing that. As a patient, how can you help your caregiver and advocate for them to take care of themselves as well?
I I think by letting them know that it's okay, that you're okay if they take some time off from caregiving, that they go do something else to help them, and actually encourage them to do that. So many situations that I was involved in, patients had been in the hospital or had been at home, and the caregiver, quite frankly, when they would come into the clinic or the hospital with the patient, they looked worse than the patient did. And I think that that's because the caregiver, who's healthy, quote unquote, is expected to be available, ready to go, great attitude, 24/7, 365, and that just can't happen. But the one person that has the power to give them time off is the patient. And the patient has to do that. It's great to think of yourself in that situation, but that person across from you has been at it nonstop as well, and they need time off. And the only way they can help you is if they go out there and get that time off. And you've got to be the one to encourage that.
That's a fantastic point. And also just giving a plug here for our support group leader network at the PFF. There are specific support groups. Well, there's a number of support groups that you can find either locally or virtually, but there's also support groups specifically for caregivers, and having that sense of community there and having the support group with fellow caregivers and be able to have those conversations. We have our PFF Caring Conversations. That is the first Tuesday every month. And I recommend, if anyone is looking for support there, if a patient that your caregiver is looking for that support, to share that out with them. We have that on our website.
Yeah.
If there are any other questions that people would like to submit in the chat, feel free to do so. I'm trying to think of one myself right now. But thank you so much, Dr. Weil. This was an amazing presentation, and I think really touches on the components that people sometimes, as we're worrying so much about our physical health, needing to think through, telling our story, kind of having that reflection, being able to do that. How can someone who perhaps in their doctor visits is really focusing on letting their physician know, I think, as you said, like, so what's going on, or why are you here today? Focus on just the physical components, and maybe they know that they're struggling mentally and needing to have that. How would they kind of approach that in their doctor visit? I feel like so many of us just focus on our physical health, and how can we have that conversation about the whole person?
I think it goes back to scheduling that separate time. I really do. I think there's a clock inside of every doctor's head that's running all the time. It's one of the parts of the profession that I wasn't crazy about, but I think there's this clock running, and I think that you'll actually find a more receptive, empathetic audience if you get them out of that setting to talk to you in a separate way. I would have a list of patients that I would just call on the phone, that my nurses and I organized time and place for me to call them. And it was better for me and it was better for them if I talked to them in a separate setting like that. There's something about having a waiting room full of patients that makes the doctor go so fast. I mean, they're not going fast for no reason. They're going fast because there's a waiting room full of patients. And I think it's back to my other point about getting that separate time scheduled.
Mhm.
And I think you can really do that. Um,
Great. Well, thank you so much, Dr. Weil. Oh, we have one question here. Um, As a support group leader, patients join the group at all different levels and all different parts of their journey with pulmonary fibrosis. How do we, and this is maybe their words, how do we not frighten people, but why by like stories of others or giving, sometimes people think we're giving too much information, but wanting to make sure we're sharing out enough information for them.
Yeah, I've always worried about that issue. It's a real valid point. I mean, I worried about it with regard to both of my books. I wrote two books about the subject matter. One, nonfiction, and my latest book is a novel that goes into a lot of the same issues. And I worried about it. As much as I worried about it, I actually found that patients respond much better to the truth than they do to some dancing around the truth, I think humans are like that. If they know what to expect, even if it's not good, it's so much better than a surprise. It's so much better than, not being transparent. So it's a fine line though. And I walked it a lot during the time I was in the hospital between delivering the hard truth, as I said in my talk, and also offering hope. I think it's just a fine line. It's kind of a skill that you learn after talking with patients one after another. And I don't know exactly how to do it. I don't know how to tell somebody how to do it, but I think you can do both. You can tell them the truth and you can also offer hope.
I definitely agree with that. And I think also everyone has their different ways of delivering or like receiving information and delivering it. And I think as you build that relationship with people in your support group or just on a more individual level, like you were saying, having the physician see the person as a person and reminding them that with their story is really important. One of our attendees said that they find emails with their doctor to help during these like visits because um, it can shorten appointments. Do you think it's a viable alternative to having longer appointments or setting up a separate appointment?
Do I think emails are? Yeah, I do. And doctors differ in their willingness to engage in an email conversation. And you'll just have to figure out if your doctor wants to do that with you or not. I'm sure it's no surprise that many doctors are using AI to answer emails. You'll be able to figure out if your doctor is one of those. It usually takes about one email to figure that out. Um, I just asked your doctor, how do you want to have this conversation? Do you want to have a separate time to talk? Do you want to do it over the phone one day? Do you want to do it by email? I would leave it up to him or her to tell you how they want to do it.
No, I think that's a great advice. And yeah, to get the best personal connection with them is to find what's the best way to connect with
Yeah.
them. One of the questions we have is there any action afoot by doctors to contact insurance companies in order to have more time to see individual patients to help provide better care?
Yeah, there really is. It's not only insurance companies, it's the way hospital administrators run hospitals. There's a lot of different influences trying to get more patients seen by physicians in a shorter period of time. Nearly everything about the industry is directed toward that goal. Now, that's not good for patients. It's not good for the doctors, but that's the goal. More patients, less time. I think the best way to really remedy that problem is respectfully just to say, you haven't answered my questions. I need another opportunity at it. and then put it back to them. How do you want to do this? I think a lot of patients just leave the clinic unsatisfied and they leave it at that. And it never goes anywhere beyond that. I wouldn't suggest that. I would suggest appeal to, I think, a physician's basic instinct, which is to answer questions and provide information. And they know, and you know, that they're up against a system that doesn't support that, but they still want to do it. So give them the opportunity to do it, and I think they will.
Thank you. That's a good answer. I think that wraps up the rest of our questions for today. Thank you so much, Dr. Weil, for an amazing presentation. I know there's so much we can take away from this, and it's really important not only for our patients and caregivers and our whole PF community, but as well as all of the physicians, and really having that conversation between them both, and making sure that we're all advocating for ourselves in both ways, and that it's the person that you're working with is the physician is a person just as well. And so just making sure you're building that connection together. I really
Yep.
appreciate your time today.